When do I know when we're live streaming then? Is there a, are we doing it already and I'm just making a fool of myself? Is that thumbs up we're going? Okay. So welcome everyone to number 79 CCG meeting. This is technically our last ever board meeting in public. I'm not one for speeches, so I won't bore you all with my long speech, but I just wanted to take 30 seconds to just say thank you to everyone. I want to say everyone upstairs. I'm not actually sure who is upstairs at the minute, to be fair, but everyone who works at the CCG, because actually without them, anything that we do here in the governing body really is pointless. Everything we do is to facilitate them in order to carry out their duties and their role, to be able to then have an impact on our colleagues and patients and peers out in the community. So it is testament to the fact that actually I think we're a really good CCG. I would say damn good, but I don't want to offend anyone. You know, we're a great CCG. And I think some of that we owe to the fact that we've had a fairly stable leadership, I'd say. So many of us have been here since the start of the CCG, some of us from before that. And actually we've had very little change, if I can say at the top, but in terms of senior leadership. And I think that's really important. When you've got stability in an organisation, it means that the function is carried out with stability. And that's important for our patients and our peers and our colleagues outside who actually utilise the services that we commission. And so really, other than them, I wanted to thank you all because you make this job great. It's been great to be chair of this governing body. I don't think I ever really wanted to be chair when I first started out at the CCG, and I kind of fell into it by default. And I hope I've not done too shoddy a job, but I have really enjoyed it. And I wish the ICB all the best for the future. And I know that some of us are carrying forward, some of you, I should say, carrying forward in the ICB. And I hope you'll take a lot of that learning with you. I know you'll take a lot of that learning with you. And I think we can rest assured that our patients are going to get a fantastic service. And my colleagues, including myself, who are out there working, should reap the benefit of that as well. So, moving on. We've had apologies from Patrick, Martin, and Jerry's not back yet, Joe. So, you might do a surprise. Oh, we've got lots of surprise guests today, so we'll wait for Jerry. But at the minute, we've got apologies from Martin, Patrick, and Jerry. Any declarations of interest anyone wants to state? John?
Yes, just if I could just declare, Sam, that I did a quality and governance review of the papers prior to their publication.
Thanks, John.
Thank you.
That's what you basically just said. If there's any errors on there, it's your fault. So thank you.
Yes, I've got one.
Oh, sorry, man.
I've already put this in, but I see that it hasn't appeared on the thing. So, but just for the sake of honesty and everything else, I better declare it. I've taken up a volunteer's job now with the ambulance service, and I'm going to be the coordinator of the other people within it over North East Essex and the Suffolk areas that we represent at the moment. So I know the areas, and I probably know some of the people once I get to know them as well. But that is an interest I should declare today.
Thank you, Mona. That's a fantastic appointment, and I wish you all the best with that. Anyone else that I missed? No, perfect. Are you right to turn your mic off, Mona? Thank you. So, can we go to the minutes? Is everyone happy with content and accuracy?
Yes.
Okay. And matters rising in action log, they've all been complete, unless anyone's got concerns? No? In which case, we'll move on to you, Ed. Thank you.
Thank you, Chair. I mean, I think the High Sheriff and yourself just gave the perfect tribute, so I won't overdo it, but it's been such an honour to be part of this CCG for the last third of its life, I guess, last 3 years. I feel I've really learnt a huge amount, and I've really developed a lot, and that's all down to the colleagues around this table and in the system. but particularly the heart of the organisation is Hassan as chair, who's without doubt the best chair I've worked for. And I've said that to him privately, so he knows I'm not not making a blusterous statement, but it's true. He's an outstanding chair. And Pam, which is the modern day Boudicca, I'd say. So she will be leading an uprising of integrated care in Basildon and Brentwood very soon, and I know she'll make a great success of it. But Pam's 13 years of leadership and dedication and true heart has been incredible to see and just to be part of in the last 3 years from a personal perspective. So wish you well, Pam. Thank you for everything you've done. You are one of the outstanding people in Essex, there's no doubt about it. So, in terms of other things to celebrate, as we know, Colchester was a Roman city, and now it's going to be a modern-day city too. So, a great start for the new chief executive to be leading it into its city status. But I guess from a health service perspective, the economic benefits of that should be very positive in terms of the health of the population. So we're very excited about both the status and I think the significance of it from a health service perspective and attracting the best talent into North East Essex. Our community diagnostic centre in Clacton is going from strength to strength, and it has the largest throughput still in the country, which is great to see. We've had a SEND revisit in Essex, and we're waiting for the results, but there are some encouraging signs coming from that. And as we learnt earlier in part 2, we're starting to develop our Live Well neighbourhood teams really positively. And there was a launch of a community hub by the 360 group in Colchester, which was fantastic to see how it all fits together really coherently with the voluntary sector and all partners. So a lot happening in our alliance. In terms of our ICB, we're ready to launch for the 1st of July. I think all of the checks we've been through have been delivered and passed. We're just finishing the recruitment to the board, and we'll be making some announcements very soon, including our new Alliance Director for North East Essex, who will be announced today, who's Laura Taylor-Green, who'll be coming from Essex County Council, and she's currently on secondment actually at Frimley Integrated Care System, which is reputed to be one of the best systems, so she'll bring that learning with her too. So we'd be delighted to be working with Laura very soon. We're out to recruit a finance director, and again there's a bill, but it's also an opportunity to say thank you to Jane. It's our last governing body today, and for all 3 CCGs, unless we've got one coming up perhaps. But thank you, Jane, for everything you've done. The books have been balanced whilst you've been here, which is your key objective, but you've done it with such professionalism and honesty and integrity. And as a result of that, I think there's a very, very strong sense of trust and collaboration in the finance community across our system. So thank you, Jane. In terms of some of the key operational challenges, the big 3, I would say, was around clearing our backlog in terms of elective care. We are working very hard to clear our 2-week waits in the system by the end of the month. And in general, we're seeing waiting times coming down and certainly fewer patients waiting over a year. Our urgent emergency care system has been under significant pressure all through the health service, but we have generally kept on an Opal 3 rather than an Opal 4 as a system. So not the most severe escalation, and more recently we've been on Opal 2, which I think reflects the really hard work that's happened through the urgent emergency care system in our ICS. And then finally, in terms of cancer, SNF has the third highest volumes of 62-day treatments in the country. which is fantastic, and they've recovered their backlog. So some really impressive work around cancer locally. Thank you, Chair.
Thank you, Ed, for the update, and thank you for your kind words. Has anybody got questions about that update report? In which case, we'll move straight on then to the Health Forum Committee report. Myrna, thank you.
Yes, it's me. Normally, I just say it's read, but there's just one or two things I'd like to add today. I think I've always volunteered in some way most of my life for the NHS, and I've actually worked for them a few times as well. But I actually, when I joined the Health Forum Committee, I actually thought it was the best engagement that I've seen by any group that I've worked with before. And it was very effective, especially the open meetings, which we had where, you know, all right, there were some people that came to everyone, and there were some that came just when they had a problem. But we were usually able to help them in some way. Perhaps they'd heard who was speaking, and it was affecting their family or something, and you know, they would come just to hear a certain speaker, which was excellent, really. And I'd not seen that sort of engagement before, and I think you know, you are all to be congratulated in, first of all, in it being set up like that, and whatever follows it, I just hope that it has some of that in with it, and it just doesn't go over to what I've been involved in before, called the sort of normal engagement groups. And you know, it would be a great pity to lose it. That's, I feel. I'm not sure whether I should be in with the new system or not. It depends what it is. And we're all trying to help your engagement group with, you know, trying to work your way through that. But I just hope that we don't lose some of the things that were special with this one, if you know what I mean, and we don't go back to just being a normal sort of engagement group that you find in most of the trusts. I'd like to thank all of you as well. I mean, I know I've thanked you on behalf of everybody, but you have made me very welcome, and you put up with me sometimes when I've been perhaps a bit on it. But I've been very grateful as well for the friendship that I've had from all of you, and for the acceptance, and to be able to bring the patient voice to the board, which again I think is quite important. I think that's probably all that I wanted to say, but I wish you all the best for the future, whether I'm with you or not. And I shall definitely be, especially as in my new volunteering, I should, you know, definitely probably be meeting some of you again. Thank you very much.
Thank you, Myrna. And I'll just end up saying thank you every 5 seconds in this meeting on it. But if I could just thank everyone at HFC as well, including Ray, you know, for his leadership. I think it's been, I think you're right. I must confess I don't have the experience that others do of PCT days before, so I have nothing to compare it to. But you know, from the days of, I can't remember what they were called. It's a big voice, whatever. You know, those big shutdown sessions that we used to have as well. That, you know, you helped us with as HFC, and through integrating with the PPGs, the patient participation groups. You know, you've been instrumental in that of the HFC, and I agree. It'd be a shame to see that lost. I don't know whether you want to pick that up on your next paper, Lisa, just to give a little update onto what's going on next, or do you want to do it now?
Well, I'm happy to do it now, and I think it will be whatever you want it to be. I mean, the whole idea about the engagement for North East Essex is that it's co-produced by current groups, and that citizen involvement is what the citizens want it to be. We shouldn't be dictating at all about what that looks like. It should be very much what you want, and it grows from that. So and if it's not, then you need to let me know. But I'm absolutely confident that it will be. Thank you.
Thanks, Lisa. I guess what we're saying is, Myrna, is if you see it not shaping the way you think it should be, then get in touch, and we will make sure it is. Well, I won't, but hopefully my successor will. Sorry, Mark.
Thank you. Yes, I think we should keep Myrna very close and kind of be an auditor for us, a mystery shopper, because I wanted to thank you for your contributions and others who have contributed to quality in other committees, because it's been that honest challenge that is so important. We know diversity on boards, diversity within organisations, diversity of thought and challenge is what we need, so we need to take that forward. So I think, Lisa, what you've just said is right, seeing what the citizens want, but we need to, as an organisation, set up a system that allows that challenge, allows that honest conversation and that feedback from patients, because we're all so busy in our lives, we're accessing these services often in a bad way and not when we've got time to reflect and have thought about how these services are affecting us. So you have always helped with that, Myrna, and your other colleagues. So yeah, let's get the essence of that and let's make sure it's taken forward. And if you can stay in touch, that would be really, really helpful. Thank you.
Thank you, Mark, and thank you for championing the patient voice in your role. Unless there's any other questions, we'll note the report and then we'll move on to the linked theme, really. Lisa.
Thank you. So this is the fourth quarterly report of the patient and public involvement paper. And it really outlines, it's a paper that we do across Suffolk and North East Essex. It outlines the work of the involvement team and the starting to evidence some of the impact. It's not there yet, but as you'll remember from the strategy, some of the work that we want to do is not just looking at how we co-produce and redesign, but how we complete that loop and make sure that we're involving our communities in the evaluation and the ongoing evaluation of services. So the activity, involvement and some impact is shown in the paper. We've been working across a number of transformation programs, program boards, the vaccination board, and obviously at alliances, which is what we're particularly interested in here. And just to support the previous conversation, you will see on page 11 some of the work that the team have been doing with the Health Forum Committee around workshops and further workshops planned to move forward conversations about neighbourhood level involvement and how to develop effective neighbourhood conversations, as well as other work that has been supporting the development of service. So we are now moving forward to the ICB Public and Citizen Involvement Committee, and obviously within the Alliance there will be the North East Essex Alliance Citizen Involvement Committee. So we will be updating through there in future, but the strategy will be overseen at the ICB committee and with elements of it coming through to Alliance. Thank you. Thank you, Chair.
Thanks, Lisa. Mark, did you want to add anything at all?
Not on this report, Chair.
Okay, thanks. Any questions, comments? Okay. So we're asked to note the report, and obviously thank you for all the work you've done on that, on the report, Lisa. And you know, as we said earlier on with the previous paper, look forward to more and more constructive engagement, I think, going forwards. Thank you. So, are you going to talk us through the research paper again then, Lisa? Sorry, what did you decide?
I am going to talk to the research paper. So I'm really pleased to present the research strategy, which is the first for Suffolk and North East Essex, and I will be handing it over to my colleague Andrew Kelso in the future, but this work started before Andrew joined us. So and I'm really presenting it on behalf of Claire Sims, who is Head of Research Management, hosted by the Norfolk and Waveney CCGs, who did an amazing job chairing two stakeholder workshops that we had in December to set out the vision and the aims for the ICS over the next 5 years. So see in the paper we wanted to keep this relatively short and punchy. We feel it's been roadshowed through many different groups and has been approved through all the groups that it's been to. It really sets the vision as one of building a culture of research. There are 5 key aims that we would like to commit to over the next few years. And the feedback from the workshops was to not have research sitting over here as something that the doctors do, but to really create a system where research is accessible to everybody, to bring together the partnerships that we work with on research, so the integrated care academies, the health and care academy, the AIU, UOS, our HEI providers, and to look at those and build on those academic partnerships. And yeah, people want research to be meaningful to them. They really want to be able to understand it and to work with it on a day-to-day basis. So the 5 aims are in there, and then as you go through the strategy, there is really clear measures that we will be using and outcomes that we will be wanting to achieve by 2027, which is really about building the profile of research within SNE. It's something that is kind of long overdue. There's really big pockets of practitioners working on research, but building the profile of research across the ICS is a really felt really important to the people that joined the workshops, and empowering individuals. So I hope it's understandable, because that would be a really good start if everybody could understand the strategy. And I'll take any questions. But as I say, massive thanks to Claire Sims, who has really been driving this work. Thank you.
Thank you, Lisa. Have we got any questions? Max.
Thanks, Lisa. Yeah, I think it is a good strategy. I think there's a couple of things I would like to make sure that is dealt with go forward in terms of
Speak up
research.
a bit, Max. Sorry.
Sorry, a couple of things I'd like to get dealt with in terms of the research going forward. And I think, you got the suicide mentioned in there, and we've got also the issues around mortality rates, the differentials in terms of health inequalities. So I think it would be really great if we could do more research into what we actually mention, and there's a really good paper, Andrew might have seen it, from the University of Cambridge about cardiovascular outcomes in east of England. And actually, there's stuff that we do that widens inequalities, because actually the worried well tend to use it more than the people who live in deprived areas. And there's stuff that we do that don't make any difference to inequalities. There's stuff that we do that actually can reduce inequalities. And so when we are actually looking at anything that we do as an organisation, I think we need to really analyse it in that regard. And also, in terms of suicide, it would be really useful to get some qualitative research into why our suicide rates are high in North East Essex. I'm not sure that we've got that anywhere. We don't. So we've got lots of ideas about addressing it. We don't actually know exactly why the rates are high in North East. So
Borough Council has just commissioned Professor Essex very subject, because in the relatively short time that I've been involved in trying to get to grips with some of the background information as to why Colchester and Tendring has such high rates of suicide, I've failed miserably to identify the root causes. So the Institute of Public Health, which was launched in February, which I know some people around this table were involved in, I met Professor Chiara, and she was quite stunned, I think, to find that we didn't have the answer to that question. So work is happening. So I could give you the connection now, which is with our own Lucy Bredman, who's Assistant Director for Communities, and the Institute of Health, Chiara. I am afraid I cannot remember her full title off the top of my head, but that will be enough. She's the lead director for the Institute of Public Health, and I know that both Pam and Ed have connections with that new and developing institute.
Thank you, Pam. Anyone else? Frida?
Yeah, thanks, Lisa. I think it's a great strategy in terms of alignment of research with health inequalities for our area and where that can go. The only thing I think is there is research going on currently, especially in as I know, in primary care. So how will you draw that in, or would that be allowed to continue in its own way? Because at the moment we just have our individual research projects going on, mainly from pharmaceutical industries helping and supporting general practice in that. So would you want that to align specifically along with this strategy, or could that just continue in its fairly fragmented way in
So I feel awkward answering this when it's Andrew's work really going forward, but I suspect one of the things that Andrew will want to do is to scope out what's happening, and then to look at one of the key aims is about that is the infrastructure. So actually we've got lots and lots of fragmented bits. We've got the UEA healthcare partnership, which we fund to have priority areas for research. We've got the Integrated Care Academy. As you say, we've got this work, we've got the work that Pam, there's so many bits of work happening, and it doesn't all have a home. So I suspect that one of the things that Andrew will want to do is to look at all the different work that's happening and look at how that can all come together.
Thanks, Lisa. Before you come in, so it's not quite that fragmented in primary care, Frida. So aside from the pharmaceutical company-sponsored research, there is still the clinical research network, which, what's the word? I won't say authorises, but doesn't, but really allocates, coordinates research within primary care. And what I was going to say was, as a primary care research-ready practice, and we're involved in several research studies every year. And actually, it's key because it maintains interest for some staff, so clinical and non-clinical staff in terms of being interested, but also patients. And you know, one of the things that resonated with me when you were talking about the strategy was about, you know, research isn't about us necessarily. It's not necessarily about the clinicians, because every time something shows up in the Daily Mail, patients knock on our door saying, I want to get involved in this research project. So patients are real advocates, or they'll see something on the internet that's happening in America or whatever, and they want to get involved. And so actually, you know, we can take all of that and champion some of that. One of the things I was going to say, there's an email trail going outside of this board to Jane, which is around funding allocation for research. And as I understand it, some of that has been allocated within North East Essex. And we just need to have clear streams of how that is fed through to organisations, be it primary care or secondary care, to make sure that we actually utilise that, because it's one of those pots that's hidden somewhere in Ed's wallet that nobody necessarily is able to always access. So we just need to open that wallet and start to use some of that. Andrew, did you want to say something? You look like you want to. Yeah, can you just come to a mic if that's all right? Just sorry to inconvenience you. We didn't think to get you one.
Right, is that on? Yeah. Sorry for the pause. And sorry, Lisa, I didn't mean to put you on the spot, having to try and read my mind and answer for me. Although we have discussed this, and what Lisa describes is exactly what my view is on research. And I just wanted to add that this strategy is an inclusive strategy, not an exclusive one. So it's not defining what the system is going to do research on and then excluding everything else and cutting it free. It's setting some priorities, but also including other research. And my view of research and the system is that the system will be able to deliver very little research on it. So the board will be able to deliver very little research, but the system itself will deliver an enormous amount of research. And part of the job of the partnership and part of the job of the board is to draw that together and to make it accessible in one place, to make sure that the opportunities from research are maximised for patients and for citizens,
to make sure that learning from research is maximised across the system, and to make sure that some of the enablers that you described, Chair, are used effectively. And we leverage as much power as we can across the system via the board to enable research where it needs to happen in the sorts of things that we need to research. And that will be defined by your colleagues and by your patients as much as by anybody else. So I hope that's a reassuring answer to the question.
Thank you, Andrew. Richard, did you still want to come in?
Yeah, just briefly. So I think it's helpful to raise the profile of this through the strategy, and the five aims I think are really helpful, because whatever we do in terms of the refresh of the ICS strategy, which we're going to need to do by December, I still think it won't cause an issue with the aims that are in the paper, and I like the fact they're really clearly measured. I think this clearly links to strategy and innovation as well. So Andrew and you are picking up how we make sure that we're integrating all of those three elements together. So for instance, we had an innovation workshop, which some of you will have been at a couple of weeks ago, and there's a real appetite from system partners to, in a similar way to research, I guess, understand what each other's doing, because there's a huge amount of work happening in that space, and there's an overlap between research and innovation. So we've just got a bit more thinking to do on what any kind of formal structure or whatever might be to support some of this as well.
Thanks, Richard. Pam?
Yeah, thank you. So my appeal on research is to address the point that Max makes around inequality. So we've got a unique position here around having some also engaged practices in our most deprived populations that are doing research on the most entrenched long-term conditions that widen the health inequalities gap. If we don't keep them engaged, we're going to lose a tranche of people that would benefit most from the drug trials, etc., etc. Traditionally, those communities don't come forward to participate in research because they don't come forward to participate in their healthcare. So if we can really positively bias it towards health inequalities, we're likely to gain a lot more from it. So coordinating with NIH, National Institute of Health Research, NIHR, the work that we're doing in primary care and the alliance around that inequalities piece. So I'll make sure that you're both versed on that, as well as the work that around, I think, the establishment of the coastal communities research element of the University Institute of Public Health, because the position around coastal communities, if you look at the Chief Medical Officer's report, is very significant bits of health inequality because of the geography, because of the single side of opportunity that a coastal community has around it. So that's my parting appeal, is that we continue to make sure that our research groups are reflective of our communities.
Thank you, Pam. Anyone else? Prashant?
Just like to make a simple point and to elaborate on what Pam's saying. As this topic was being unfolded and presented, it just me that our social care colleagues already do a JNA, and they make the priorities for the region. So maybe sort of dovetailing this with that priority list and doing the research in the priority areas, outcomes, you'll have tangible outcomes which can be measured.
Thank you, Prashant. Yeah, very important that we start to utilise the system. Oh, Paul.
Yeah, so just want to join the dots up a little bit. I think we've got a real opportunity in terms of the research strategy to not make research elitist, but part of what we do every day. We commission services in quite significant quantities every day, and actually we should have a culture of research and best practice. So actually how we then joined up that element to what we do and not have to think about it in research term is really where I think we need to land, and then that gives an opening to sort of more elitist type research, but actually everybody should be involved in that research element as part of the commissioning cycle.
I completely agree. And actually, although it's, as a clinician, technically the exciting side of research is the research process, but actually it's very important, very, very important. Well, who didn't know such a good debate about that paper, Lisa? Thank you for bringing it up, and thank you for, sorry that Claire couldn't make it. Thank you if she's listening out there. Right, so we're asked to adopt the strategy, so don't see anyone objecting. Perfect. And let's move on then to 22-23 plan. That's you, Jane.
It is. I will start, but I'm actually going to hand over pretty much straight away to my exec colleagues. As included in the plan are a number of items, and individual directors are going to take you through the various, starting with Richard, and I'll come back at the end to talk about the finances.
Thank you, Jane. So, as Jane said, most of us will be chipping in on this, and I think it says a lot about the process that we've been through in terms of integrated planning for this financial year into NHS England. So, as you'll see in the paper, there's a number of different parts to it that we've had to submit. It's all gone in, but we've been given the opportunity, if I can put it like that, to do a further submission on the 20th of June, just with any final changes, and directors will touch on those, I'm sure, as we go through. So the part that I've been leading is the narrative submission. So effectively that's the narrative plan that accompanies the asks that NHS England have made to us for 22-23. So that's at section 4.2. And you'll see the full plan in Appendix A, those of you who have had a chance to go through. Just to touch on what the main sections of that narrative plan actually are. The first one, importantly, is health inequalities. As we all know, that's a golden thread running through our ICS strategy, but there are specific requirements that NHS England have set for us that are set out in the guidance document. So we've gone through that and responded to that as a system. Second area is that Amanda will touch on in more detail in a second is workforce. So we've had to put a narrative plan against what our plans are over a longer time trajectory for workforce planning, what are the risks and some of the opportunities around that. The next one is elective that Paul will touch on, which is our elective recovery planning, the specific requirements that Paul will go through related to that. The next one, which is with myself, is cancer. Ed touched on it in his opening remarks earlier in terms of how we're going to achieve the national cancer waiting times, particularly 62 days, 31 days and the 28-day faster diagnosis as an ICS system. The next one is a shared endeavour across Paul and I on diagnostics. So there's an element there again on recovery. So what more can we do to get back to 120% actually of activity against pre-COVID levels, but also the element that I'm leading on is the development of the community diagnostic centres. As we know, within North East Essex, we're leading the way on that with the Clacton development that's now moving into its second stage. The next one is urgent emergency care that Paul's coordinating with Pam and the other two alliance directors in SNE. That's particularly related to some of our main waiting time standards around ambulance handover delays, A&E performance, and then it segues into community services, which Pam's leading on for North East Essex, which is particularly around our discharge rates, our care home work, etc., etc. So it's fair to say that majority of it, if not all of it, we've actually got underway, and we've crystallised that in that narrative plan. So when we finish, happy to take any questions around that, and I'm going to hand over to Paul for the activity and performance element.
Thanks, Richard. I was reflecting on the paper last night to see how do I summarise what is a lot of words. And what I reflected on was nothing in that narrative should be a great surprise to anybody, because we've actually been discussing it on and off. And what was really heartening as I was rereading the plan was I could actually point to every single one of those lines and say we're actually doing it. So in some respect that plan was actually quite easy to write because we were actually living and breathing many of those issues. Just to start on the elective side of things, in some respect the planning requirements are quite prescriptive. They talk about a number of things. Forgive me, I'll go through a few figures in a second, but there is an absolute expectation that we should eradicate 104-week waits by the end of June, so no patient waiting longer than 2 years by the end of June. I'll talk about that probably in the IPR report as to where we've got to with that. There is an aspiration that we should have no patients waiting longer than 78 weeks by the end of March 2023. As a planning submission, we are about 380 patients short at the moment. Bearing in mind that we're talking thousands of patients going through and being managed appropriately through that transition, so it's not just 300 patients not being treated. The system is carrying working towards those plans with mutual aid and other aspiration, and we will carry on working to try and make sure we actually get there. The bulk of the issues sit around gynecology, TNO, which are the high-level specialties, not forgetting that pre-pandemic, these were the specialties where there were some challenges already anyway. So this is not just about pandemic, this is about sort of historical catch-up as well as we move forward. In order to achieve recovery, for want of a better word. 22-23 sets us a challenge of achieving 110% of activity compared to 1920 baseline, rapidly moving to 130% in 22-23. Now, clearly, in that respect, and of course, then there is a finance element of that, and there is an ERF type process where it attracts additional funding should you achieve above 104% of threshold in terms of finances. So again, if you want, the narrative explains how we're going to get there in quite a lot of details. And finally, there is a whole piece around outpatient transformation, which is around patient-activated follow-ups, non-face-to-face activity and advice and guidance, to in some respect to try and manage, improve capacity, manage patients very differently, which is why, again, there's a really important conversation to be had at alliance space and conversation between IQ Trust and that wider conversation with our primary care colleagues. How it's broadly going to be looking to achieve that? Number of ways. Real focus productivity. Can we do more through our theatres? Review of our high volume, low acuity pathways. Clearly, there is actual capacity requirements, and there has been a number of capital bills recently to help us to do that, and some Vanguard theatre usage as well along the way. Mutual aid has been a really strong feature of what we've been doing, and just to reflect, this year we have managed over 1,000 patients differently than we would have done traditionally through the use of mutual aid, through the use of private sector, etc., etc. So again, massive achievement in terms system as to where we are, and of course our private sector partners have been a key partner in trying to achieve some of that. Clearly, caveated, we know that there are a number of risks. COVID, without stating the obvious, finance being following in the activity that we need to deliver, and of course there are some infrastructural issues within the system around West Suffolk, and I'm sure as you know, we've talked previously, SNF have been heavily supporting West Suffolk because of their limited capacity around elective activity. So again, there are some risks that are actually embodied within the narrative. Moving sort of swiftly around urgent care, really difficult one to summarise because it's actually quite a all-encompassing sort of multifactorial approach to how we can improve our urgent care. But I think the thing I would say that it recognises the importance of getting urgent care right to get the elective right. So if you don't manage urgent care, you stifle elective activity and therefore you don't meet your recovery. So again, you need to do both. You can't simply just concentrate on one thing and not the other. So broadly speaking, the focus of the planning submission sits around, how do we manage demand? How do you actually manage your front door pressures? Ambulance delays, for example, flows within the A&E department, etc. Talks about prevention. Prevention is usually important, and planning patients better in an integrated way is usually important in managing patients differently, and the system partnership is required to do that. And then finally, the only thing to say is all of this really is then triangulated against workforce and finances to make sure that our plans just together. And the figures that you see behind all of this, which are tables and tables, are essentially an expression of that narrative in terms of how the figures translate to activity and figures to achieve the numbers we would achieve. So I'm going to stop there. I've said quite a bit. Quite happy to answer any questions. Thank you.
Shall we move on to all the directors? We can bunch of questions together, if that's right. You next, man.
Thank you very much, Chair. So building on what Paul said, the workforce plan has been pretty much put together as a collaboration with all system partners over many months. There is a lot of detail behind the narrative, but in essence, we are projecting over the next year a growth in our overall establishment, which translates into about a 2% increase in headcount by the time we get to March 23. The ambition of our People Board, which is basically the group that oversees all things workforce across the system, remains that to be a one workforce, so we're not differentiating health and care, but bringing in the total workforce over time. It is a challenge and is a risk, but that remains one of our number one ambitions as we move forward, which ultimately will be delivered through the People Board at system level and in each of the three alliances. In terms of the key programmes of work, they pretty much focus in three main areas, which are included in the report. One, supporting our current workforce across health and care, belonging to the health and care sector in its entirety, and looking and different way from our traditional approach to workforce planning, which has been done year on year, to a much more systemic approach where we're looking at the longer term, the 3 to 5 year. So we're about to embrace on that as we move forward. So it's moving away from what we've traditionally done and being comfortable in doing to being something very different. And alongside that, we continue to want to work with a fairly new partner, and that's the Integrated Care Academy that's been in existence for just over a year, a key stakeholder and a key partner within our overall people plan. And we're doing some really amazing work with them. And one is actually a project that we hope will come to fruition during the end of this calendar year. And that's to develop an integrated care apprenticeship. And we think that, that's the first of its type across health and care. And we're really quite proud to be leading the way on that. So hopefully that will come to fruition, probably towards the end of this year, where we look to roll out beyond SNE, but to that regionally and hopefully beyond going forward. I'll pause there, Chair, but happy to take questions.
Thank you, Amanda. Who's next? It's back to you, Jane. Right.
It is, yes. So thank you. We'll move on to the final section, and as Hassan said, happy to take any questions at the end. So the final section is on the financial plan for 22-23 and the budget, and I think it's fair to say that it's been a complex year to get the financial plan together, and that's for a number of reasons. Firstly, because when the national team were looking at the allocations for the year that started a few weeks ago, they were looking at ICBs forming from the 1st of April. So we were expecting to have one allocation for the system from that point in time. They were also looking at inflation levels that were much lower than we're now experiencing. And there was also a prediction that that COVID would be on the decline, and we wouldn't have seen the wave of COVID that we saw in March, April time. So all of those three things meant that the funding that was allocated to the NHS has proved quite tricky to get towards financial balance. The second reason for us why it's tricky is that we've had to navigate an allocation that's given across the whole of Suffolk and North East Essex, but deal with the fact that we are still CCGs for the first quarters, moving into the ICB for the next part. So it's been a moving story, and thank you to the Finance Committee we've been taking on that journey with us. This what you've presented in the papers is the position as at a couple of weeks ago, when we as a system had for the commissioning part, so the CCGs going into the ICB, had pulled together a plan reflecting the impact of COVID inflation and the existing pressures within our budget. And we had presented a plan which was out of balance for the three CCGs and the ICB of 18.5 million, and that's shown on page 169 if you're following them in your pack, towards the end of the slide 7 of the presentation. So what's happened is that position was in line with much of the rest of the country, and further work has been done at national level to pull that together and also to look at what additional resource might be available. So since this paper was pulled together, the system has received notification that additional resources are coming our way, a combination of recurrent and non-recurrent resources. They will not be sufficient in themselves to close the gap, either within the commissioning part or in our provider organisations, but they will go a long way towards that. And across the system, we're continuing to work on what we need to do around financial recovery, what we need to look at in terms of any non-recurrent flexibilities that we've got, and the use of the new funding in order to get ourselves, hopefully, to the position of being able to put in balance plans on the 20th of June. So, but in terms of what we're actually asking for today, it's actually fairly straightforward from the CCG's point of view. So if you look at page 170 in the pack, which is the final slide, the way that the finances work this year, because it is very complex, is that effectively the CCGs for the 3 months that we still exist will spend the resources that are required, and they'll be given allocation to match. So effectively we are working in a break-even position for the CCGs, and any problems that causes, because we've used too much resource or whatever, washes up into the ICB. So obviously the new resources that come along will have a bit of an impact on the CCG, but effectively what it will do is it means that there'll be more left for the ICB to be able to balance as we get into that second half of the year. So what the actual task of the governing body today is to agree the budgets for the 3 months that have nearly finished now of the CCG that are set out on slide 8, noting that that will be matched by allocation, and effectively the CCG will end up in a balanced position. We are currently working through the changes associated with the extra bits of money, and we will be taking those to a combination of finance committees or governing bodies over the next couple of weeks, in order that we can put forward our financial plan for the ICB, but that will be for the ICB to sign off. So what I'm actually asking you today is to approve a balanced plan. The opening version of that is given on slide 8. It may change slightly for the better in terms of spending power, but it will still continue to be a balanced position.
Done? Oh gosh, that was almost a board meeting in itself, isn't it, that paper? So quite a big plan, and actually really important. And unfortunately, neither Martin or Jerry are here, but I can add us on that last point. They're content with that plan, aren't they, because of the email traffic around sign-off. So open to questions. Pam.
Thank you, Hassan. So my points are relating directly to Amanda's presentation with regard to workforce. So first of all, just be keen to understand that all local authorities are playing a full part in the People Board. And if that's not the case, it'd be good to know which ones are and which ones aren't. Secondly, just to make sure we don't miss the chance to change the demographic profile of the workforce through some of the anchor work that's going on, which of course Ed and Laura, when she arrives, will be very familiar with. And thirdly, I'm a great fan of joint posts and can't wait to really embed the joint post of Alliance Director into my own organisation, into the Borough Council, and recognise the work that Pam's already done to make sure that that's achieved. I'd just like to see more reference in there to future development of joint posts, because I think they're a great way of bringing resources together around a shared purpose. Thank you.
Thank you, Pam. Amanda, are you able to respond?
Thank you very much, Chair. Thank you very much, Pam, for those challenges. So if I take each of the points in turn, starting with local authority presence, at the People Board, we do have your organisation and indeed others represented, which is good. And I'm pretty sure that actually reflects in each of the 3 alliances in terms of their workforce groups as well. In terms of joint appointments, we are starting, and we have got examples of that already, but we need to do more of that. But just to give you one example, we have at system level within the workforce space just created a joint post leading on the, so that's one example, and there'll be further examples that we need to be embracing as we move forward.
Sure.
So is that a new post that's about to be advertised, or do you already have a joint post on that one?
It's a joint post that was advertised probably a couple of months ago, and we're just about to invite the new person to join us.
Okay, thank you.
Thank you, Amanda. Frida.
Yeah, thank you. My point is also to poor Amanda about workforce. Thank you for that, all of you. It is a huge paper, so yeah, it's big. But just in a very small point, workforce, well, it's not a small point, but in terms of this paper, in terms of medical workforce, clinical workforce in the community, or it's certainly in ESNEF, and you talk about retaining and recruiting, it's a national problem. So it's a huge challenge to any sort of nursing or medical body, really. What makes us, what the ideas that are different? You said at the beginning that it's about doing things differently. What would be different to what hasn't been attempted already? And also looking at coastal areas, which we have, particularly where I work around tendering, you know, to even keep, you know, we work on such an edge that if we lose one GP, we fall over. You know, that's how tight we are in general practice in tendering in Clacton. And we had 2 off sick the other day, and I can't even feel damaged by the experience. So you know, what is going to make us different? And my last is that when you talk about Rs roles and PCNs and non-Rs roles, they are very dependent on estate, and we don't have the estates. And until we have the estates to accommodate the future outlook with regard to ancillary staffing through PCNRs roles or non-Rs roles, then I don't see us going very far with any of these, sadly, because I think they are really good initiatives about helping and getting more multidisciplinary, but we don't have the estates, and that's a fundamental problem.
Can you fix it, Amanda?
Well, no, but thank you, Frida. I think absolutely the points that you've made are well made and absolutely key to everything that we do day in, day out. So let me just take in perhaps reverse order the estate challenge. It's immense, and we are very much aware that the creation of additional the roles requires extra estate. We know finances are a challenge and continue. We recently took a paper focusing on primary care estate to the ICS board in January. It had a number of recommendations which were partly supported, but it's work in progress. But I think the positive of that paper and that discussion was it was acknowledged by the wider board that we have got an issue and we cannot ignore, and we need to resolve it together. And I think it's fair to say that all system partners acknowledge the challenge and realise that we need to do something. The primary care estate has been badly neglected for too long, quite frankly. So that's why we now need to be rallying and coming together as system leaders to really focus on fixing primary care. It won't happen overnight, but I know there is a general acknowledgement now, and I also know that there is an estate updated paper on the actions that we presented in January going back, not this Friday, but at the next meeting, I believe. But it very much is on everybody's radar, and indeed Ed's radar, and is something that we need to solve, but systematically. It cannot be just one partner. It probably hasn't answered your question, Frida, but it's acknowledging that it's now being heard at the highest level.
Yeah, which is great, which is exactly where it needs to be heard, because I don't think there is a solution unless there's a huge investment.
Indeed.
But the problem is that we can't accommodate what's expected of us at the very frontline level, at the bottom,
exactly,
on ground. So that's the problem we have.
Indeed. And just going back to the investment issue, we have identified a proposal that actually looks at capital allocations that we receive at system level and how we look at using that allocation very differently to how we've used it traditionally. So there are things being worked up by a subgroup of the estates and the directors of finance that can work through and come up with some solutions that hopefully will benefit primary care as we move forward.
Thank you both. That's a really complicated challenge, and I'll call it a minefield, isn't it, in terms of primary care estate, because not only is it the challenge of money, it's also the challenge of the model that we've got in primary care of GP-owned estate and patient access. And so, if one thing the ICB can do, or hopefully can do, it should be that system involvement. So when, and we've seen it in a few practices where there's council-owned buildings or council-owned land, which then can be utilised in primary care, and so there are various models. So the model, realistically, the model is going to have to change, because we were having this conversation earlier on. Primary care in its own right, in its current format, isn't necessarily sustainable, and it means the model needs to change, and that means the estate needs to change. So it's a big piece of work. So good luck.
Can I pick up on a couple of other points that Frida raised,
Sure.
if I may? So you're right, what's going to be different? And I think we do need to be thinking how we recruit and retain, but in a different way. And things like introducing portfolio careers and making careers more varied and more interesting is something that we have to consider. And I think working alongside the Suffolk and North East Essex training hub will give us that opportunity to get into a different way and a different mindset of how we've traditionally done things in the past. So I'm quietly confident through the leadership and the growth in that team over recent months that they are taking a different and a more vibrant approach to how we do things across primary care.
I also sincerely hope that NHS England will give up on some of the rigidity around the ARRS posts, because Actually, if they were able to do that and we were able to utilise that locally and make decisions locally, I think we'd be able to plan our workforce in a far, far better way. Sorry, Frida, you're going to come back.
I was just going to say that actually, you know, after all these years of bringing up this point, it's actually really nice to hear that actually it is at system level and it is being discussed. And I recognise how difficult a problem it is, and I do also recognise that the model needs to change, and it may not be what all of us want, but it does need to change in order to accommodate the needs of the population in the community, and I get that. But it's good that it's really good to hear that it's being discussed now in a more purposeful way than perhaps it has been before.
And if I could just make one final comment in terms of that system, we do have primary care represented at that system people board level, which is vital.
Okay, thank you. Myrna.
Yeah, I wonder if it's possible to have a bit more information about joint posts and things. I don't understand quite how it's going to work for everybody. What I'm trying to say is that, you know, I'm looking at the patients here. Yeah, is that going to be more equalities in some of the poorer areas where they maybe can't afford or have the facilities to take on something like a joint post? And, you know, just want to be reassured. And I wonder if you could, you know, I don't want to give you more work, but just is there a paper already there on it, or is something I could read? So I'd like to understand what it means to the ordinary person in the street.
Mona, I'm very happy to, I'm sure I've got something that I can share with you that really articulates the benefits of joint appointments and how it translates into members of the public and the like. So very happy to take that offline and have a conversation with you as well.
Thanks. Is that about this, Lisa?
Yeah, I was just to support Amanda. So Richard and I both have joint posts across our Suffolk County Council and our Children and Young People team, and what it means is that the health and social care element of CYP is brought very closely together, and they can see both sides. So I think that does make a huge impact. So things on a practical example. So Leanne, who works in my team, she also within her portfolio has the health visiting and school nurses in Suffolk. That she runs those for Suffolk County Council. So when we were doing the Children and Young People vaccination programme, she was ideally placed from health to look at how vaccinating early years and education from the 5 to 12-year-olds, how that could be operationalised. So I think we've got lots of examples of how joint posts can make impact on people, but we probably don't talk about them enough, Myrna.
No. I was just more concerned about the areas that are already suffering from, you know, deprivation in different ways. I just didn't want them to be then sort of have other problems with being able to get good health care because of, you know, of what was happening with shared posts and things. I just couldn't understand that. So I just wanted to know a little bit more about it so that, you know, somebody asks me, I can explain it to them. Thank you.
That's a good question, Myrna. Mark.
Thank you, Chair. I just wanted to come in. I don't know enough about it, but I was on a national board this morning for children and young people, so referring to Lisa's point indirectly, and the silo working still is immense. It needs to be broken down, and we need to work closer, because we have local government performing some stuff, NHS performing others, different partners out there, the public sector and third sector. So what we've done here in the alliance work is incredible, and we heard from the High Sheriff earlier about how far ahead we are, and we really are, and I think that should always be a selling point for staff coming to work for us. So from my sort of point of view from local government and NHS and other public sector bodies, I support Pam's earlier point about more joint working, and I don't think it's about front line as such. It's about the sort of organisation behind, linking together, that enables the front line people to get the message from the county council, from the district council, from the health, from the middle sort of boards that are going on, to actually go, right, here's the information, instead of you getting it from 4 different places, we've all worked together, and there's the opportunity for the frontline worker to deliver for the resident, for the citizen, for the patient. I actually see it as the right way to go. You will avoid some duplications. You will avoid some of the bits that fall through the net that we hear about, unfortunately, where patients really suffer. So I see it only as a positive. And yes, it may sound confusing at this point sometimes, and I'm not totally sure how it all fits together, but I know that the Alliance Director role is going to help working together. These are roles that are more organisational, that will help the front line then to deliver for our people. So I think it's a good thing.
Yeah, I'm sure you're right, but I just want to be able to understand that.
Yeah.
So that if somebody asks me a question, I can tell them.
I think it's a reasonable request, Manna, because if you know, if we can provide something that would explain it better for HFC, then that's useful. Anyone else got any questions around it? I don't want to drag it on unnecessarily. Okay. You will need an extra £2, Jane, there, because the blind just broke. So, should we have a whip? We could have a whip round later. So we're asked to approve plans A, B, C, D, and to delegate to Finance Committee if there's minor adjustments. Everybody happy? Okay, thank you. Now we're on to who's presenting it? Oh, Amanda. You're about to present the our future. So we get to approve the constitution for the
Absolutely.
Okay.
There has been a bit of a time lag, Chair, but we are required to present the ICB constitution to our respective governing bodies. As the paper says, the constitution is pretty much mandated to all organisations, so there is very little opportunity to add additional things to our model constitution. Work began last summertime, and since then there has been a continual discussion, debate, dialogue with system leaders as to what the constitution should look like, particularly around numbers of people representing the board at ICB. And as I alluded to earlier on, we have virtually concluded our recruitment for partner members at the ICB. And as the paper mentions, we have 16 members that will form the board from the 1st of July. And in addition to those mandated members, we have additional members that are there to observe and the like. So in terms of recruitment, we are virtually there. I mentioned the nationally mandated requirement, but and also another thing that we were required to do was to consult. And it was deemed appropriate that we consulted on our constitution with members of our ICS board and wider stakeholders. That happened during the course of the first part of this year. We then had to collate their feedback in terms of use we have done, so reflecting any comments and observations into a final draft. That final draft, given the timeframes we were working to, then was discussed and debated by the CCG's collaborative committee, and because we were working to a very tight timescale, they basically signed off the ICB constitution on behalf of the governing body, but we are still required to present the constitution to our governing body today. I think it's important to also note that there are a number of documents that sit behind the constitution in the context of a handbook. And within the handbook, we contain all of the references for the many subcommittees and committees of the board. We, just going back from memory, in terms of the mandated timeframe that we were working to, we had to submit our updated constitution to NHS England a few weeks ago. And last week, we received a letter from Region to confirm that they had signed off and finally approved the constitution so that we're ready to perform from the 1st of July. The constitution is going to be uploaded in due course on the national websites for public consumption, so I think that's something that will happen in the next few days. So in summary, Chair, I think it's fair to say a lot of it was pre-described, but we did have opportunity to decide the numbers of our board, which we have done, and the recruitment is virtually there. And yeah, I think we're in a good place, ready for the 1st of July.
Thank you, Amanda. So if we don't endorse it, do I get to keep my job? Is that... has anybody got... Ed, sorry.
Thanks for all your hard work on this, Amanda and team. It was just to add, I don't know whether this is in the Constitution or not, but that Aspen House is going to be the nominated headquarters for the Integrated Care Board.
Very good point. Apologies for missing that, but that's absolutely, and I don't think it is within the Constitution. It's within the multitudes of documents that we've had to submit to confirm our new HQ.
Exciting. It'd be great to utilise this estate, especially the investment we've made in it over time. Does that mean that there'll be face-to-face meetings with ICB, or has nobody planned that yet? Or
Yep, in terms of the ICB going forward, we are planning to have those meetings face-to-face.
Oh, exciting. Anybody else got questions? John?
Yeah, just a small point, just to say really, Amanda, in support of what you said, that I've reviewed the Constitution at different stages of development and provided feedback a couple of times, I think, in my role as a member of the joint collaborative group. I think my view is that the current draft, if it is still a draft and maybe it's a definitive document now, I think will provide the Integrated Care Board with a good basis from which to operate from a governance perspective from the 1st of July. I suspect, no doubt over time, in the light of experience, NHSEI and the board may well refine it and perhaps simplify it a bit. But I think it's a very good document and a good starting point for the ICB as it moves forward from the 1st of July. Thank you.
Thank you, John. And you're quite right. It took us about 10 years to get our constitution right, didn't it? So it's not even a joke. It actually did, didn't it? Sorry, Amanda, were you going to come back?
Yeah, I was just going to comment on the right comment that John made, in that this constitution is the beginning and we have opportunity as we mature as an ICB to review, update, tweak and the like, which we will be doing in, I think, a year's time.
Okay. So does everybody feel, thank you, Amanda, John, does everybody feel happy to endorse the constitution or not and keep me in job? No? Perfect, okay. Thank you. So now I've been told, I'm just going to check again, but I don't think we've got any questions from the public. Just, Joe, you haven't heard any more. So what we're going to do is we've got a short video that we're going to play, which I'm told works via live stream as well. So I'm looking over to my left to comms experts.
Hi there, I'm Pam Green, Chief Operating Officer of North East Essex Clinical Commissioning Group and Exec Lead of the Health and Wellbeing Alliance locally. I'm very proud to be here today presenting to you a little look back as to what we've achieved during the time of North East Essex CCG's life. I've had the privilege of being part of the senior leadership of the CCG from its inception now to its closure. And during that time, I think we truly moved from transactional relationships and the purchasing of healthcare into one of true collaboration and partnership. We've seen great adversity through the pandemic, but through that, we took the opportunity to build brilliant relationships and truly respond to the pandemic, but change our way of working to now truly reflect the health inequalities focus and the equity piece that our populations need. To move forward the health of the population with our partners alongside us. So thank you to everybody that's put so much into the time of the CCG, working as a staff member, but as well our partners. We could have done nothing without our partners, voluntary sector, districts, boroughs, all of those. And here's just a few clips to demonstrate what we've achieved over that time. So thank you once again and good luck in the integrated care system arena. Thank you.
As a GP, the benefit working as a part of the neighbourhood team has been being able to access knowledge and resources beyond the primary care setting. I've been able to speak to people from organisations I didn't even know existed, and I've made a lot of connections with my colleagues in the community that have been really helpful. This has benefited my patients because I'm able to get practical advice, often at short notice, on one occasion that was arranging some emergency housing for a patient who'd been made homeless that morning. The benefits of the Neighbourhoods MDT have really been around the wealth of knowledge available across the team, and the sense also that we're working together as part of a bigger team in the community. I think we have a much wider scope of understanding than ever before. Neighbourhood team working has really benefited our primary care team. It's given us a mechanism to have discussions about our patients that allow us to look at options beyond what we can do in just primary care. It's helped mean that we can follow a holistic approach, and the end result has been less focus really on what we can do in primary care for non-medical problems, looking at the patient as a whole and how they can be better served by services in the community.
Hi, my name's Mark Shorter. Welcome to the quick presentation about the Shell's SOS bus and what it's achieved over the course of the last couple of years. This all started in March 2020 in response to the lockdown with COVID and the homeless community. It's the first time that all the partners in tendering came together in such a way, and we created the group called Shells, which is Shelter and Health Enlisting Local Support. We're all working collaboratively at strategic and operational level to support the residents. The work has not been underrated in any shape of the imagination. So we've had visits from NHS England and their performance team to come and visit the bus, and they've actively encouraged other areas right across the eastern region to take heed of the work that we're doing here in North East Essex and make sure it gets shared much wider than that. We've also had a visit from the High Sheriff of Essex, who was mightily impressed with everything that we were doing to support those most vulnerable in our community. I think one of the most important things that's come out of the work with Shells and the SOS bus is that it has formed the start of the Homelessness Alliance across North East Essex. So as a system, our partners are now coming together to ensure that all the current issues and trends are being picked up on, and we are working actively as a system to actively get solutions for them.
Looking at the paper, clearly it reflects performance in March, but I thought I'd take the opportunity really to give the current context where we are in terms of performance, in particular on urgent care and elective, given the fact we've spent some time talking about some of the planning guidance. So in summary, so As you know, we've been on a national level 4 incidence footing for quite some time. About a week and a half ago, we de-escalated to a level 3, which is great news, but we still remain in a national incident. If you'll recollect, a previous conversation demonstrated high level of COVID within our hospital sites, high level of sickness around our staffing, major issues around our patient flow within the hospital setting. If you look at the figures that have emerged straight over the weekend, 12 patients in Colchester with COVID, which is a significant improvement. That is not to say that COVID has gone away, because actually if you look at West Suffolk, you've seen the numbers increase there, but 12 patients in Colchester, about 17 patients in Ipswich Hospital. So again, it has freeing up some of the flow issues, some of the operational issues that we are experiencing. Similarly, if you look at staffing, I think the latest figures that I've seen, 3.1% sickness, of which 24% is COVID related. So again, there appears to be a bit of an abatement to actually some of the sickness challenge that we've experienced within the organisation. As Ed has already alluded to, we had probably a couple of weeks of very, very difficult weeks where we were at escalation level 4, which is the highest level of escalation we could be. And after a couple of weeks, de-escalated to level 3. And I'm pleased to report that we maintained a level 2. Whilst everything remains quite difficult out there, a lot of our other sort of systems, other systems are still operating at level 3 and beyond as we stand at the moment. It's a significant achievement given the fact that we've just gone through several bank holidays and Jubilee long bank holiday weekend, and there's been significant amount of planning by our partners in order to be able to maintain that level of safety, I guess is probably the best way I would describe it. The thing that I would highlight, though, there still remains some significant concerns around ambulance conveyancing. You'll see our C1, C2 and C3 in particular are a worry. As a system, we are doing everything that we can in terms of supporting what is a sense of regional issue as much as it is a local system issue, and we do that by a number of ways. Conveyancing avoidance schemes, and in particular one where we actually go into the waiting list of patients waiting for conveyancing and redistribute patients within the system, and we are working with to try and replicate that across the region because we think it's good practice and try and enhance that approach. And you'll notice within the paper that we do reasonably well in terms of ambulance delays at the front door, albeit every single delay is a delay too long, and we need to acknowledge that. But if you benchmark, then we're pretty much doing okay in comparison to other areas. Just as a way forward, we've established an urgent care committee now, which is started to meet to oversee performance and urgent care flow within the system, and that will progress as we move into the ICB. Earlier on, I talked about elective activity, and a few things I'd like to highlight on that is to say, so our waiting list carries on to grow, and that is a concern, and that is within the context of us having to move to 130% of activity in 23-24, so we will have to do something different, move forward. 52 weeks have started to climb a little bit, but that needs to be seen in the context of mutual aid from West Suffolk. Again, we need to look at it as a system, but we are managed to just about hold that position. We talked about the 104 weeks, and again, at the last board, I sounded confident, I was reported confident that we would achieve no 104-week waits. SNFs in particular remain on target for that. If, at last count, 28 patients are waiting over 104-week waits. They are giving me assurance that they will meet that aspiration, with the exception of auxiliary maxillofacial patients, where there is going to be a bit of a delay, but that's a regional conversation which is happening, and those will be completed by August. I have to say that it's credit to the staff who have managed to maintain that level of activity. So there's been a really, really difficult period with COVID and other issues within the system. Being at level 4, it's quite incredible that we managed to maintain that level of commitment from our partner organisation. Very quickly, iniquities. The report points to the fact that our 92nd percentile iniquity has gone from 11 to 8 weeks. It's now 6 weeks. So again, progress is still being maintained in terms of equity of access within the system, which again credit to mutual aid and all those other things which are happening. And finally, Chair, you asked last time around a bit of benchmarking, so you'll notice within the report we have put a benchmark table. And whilst I don't personally aspire just to be benchmark against region, because we want to aspire to be even better than that, is my personal view. You will notice our diagnostics were top in terms at 6 systems, which you look at 2 weeks with third, but 62 days we are top, which again expresses the view that Richard and raised earlier on in terms of our productivity around cancer. RTT, again, we top of the tree in that sense across the region. And again, when you look at our RTT position, again, we top in our regional benchmark. So again, we are doing well, but that is not to understate the challenge we have facing and moving forward. Cancer we've talked about, so I won't go into great level of detail on that. And broadly speaking, most of the rest of the report really covers some very similar issues that we've talked previously at various boards. So I won't go any further than that. That's something I'm happy to answer any questions. Thank you.
Thank you, Paul. Thank you for incorporating the comparisons, and I agree. It wasn't for achievement, well, it was for achievement, but it was just to make sure that we're not outliers. I think that was the reason I wanted to get it included. Sorry, Mark.
Thank you. I just felt I wanted to ask a question about staff as a whole, and the comparative nature that you showed us is very good. It's good to see that we are near the top in most indicators. But I just wanted to ask, because I understand from other public sector organisations there's a fragility of those who have worked through COVID, who are now doing the catch-up from COVID, who have really drawn on internal stocks of energy and continue to do so. And I just want to say I appreciate that has been done in our organisation and partner organisations. I appreciate we're near the top in some of those indicators. That is fantastic. But have we got innovative ways in which we are allowing enabling staff to refresh, to re-energise? How are we doing that? How are we maintaining a higher position? And are there any other innovative methods to learn from elsewhere about how to that resilience going forward?
I'll start, and I'm sure Amanda will want to finish. So just a few things. I think you're absolutely right to call this in terms of to challenge, in the sense that I'm talking about acute sickness and workforce. Actually, when you talked about our tactical meetings that we've been having weekly, most other providers and partners are experiencing the same issues and difficulties. Whilst I've been away for a week, I haven't quite caught up, but I think most are reflecting an easing, should we say, of the impact of COVID on workforce. I haven't got the figures, so I can't share you with those at this moment in time. But you're absolutely right, there is a conversation to be had around recovery, sustainability, particularly at a time when there is a drive to improve and recover. Is the conversation. I think for me personally, there is something, and I think there was a question earlier on around, John Post and what are we doing innovatively. My personal reflection is, are we doing everything we can well? Because actually, when you actually look at our staffing complement on this exchange, we were certainly one of the system able to have the highest level of, or the lowest level of vacancies, which put us in a really good start as a system, starting point. And I know the people board are now working on other strategies to try and improve that position. So Amanda, I don't know whether you want to comment any further on that.
Thank you very much, Paul. Yeah, so just to build on what Paul has said and to give you some confidence that we are acknowledging that. So at the System People Board, we have a subgroup that reports in and is leading at system-wide on health, wellbeing and recovery. And that has been in existence probably just over a year now. And through that work that is reported to the System People Board at every meeting, we are hearing lots of innovative practice happening within our local providers. So to give you an example, SNEFT have got a really good programme in place where they encourage one-to-one conversations with their staff to look at flex working beyond the norm, and they are encouraging their staff to take career breaks and do things differently as a way of retaining as opposed to losing them completely. So that's just one example, but we have got other examples of where we're needing to think differently because we do need to allow our staff to recover as well as retaining them longer term. So it's very much work in progress.
Thank you.
Thank you both. Anyone else got specific questions? Bit of a challenge really, isn't it? I appreciate the position, but there's still an unfortunate sea of red, isn't it? That's the concern. Jane, seeing as Martin's not here, I don't suppose you could feedback whether there's anything from F&P about this that they wanted to feed through?
In terms of the overall performance figures, I mean, F&P does look in, Paul and Vicky come to F&P and go through in a lot of detail, and they have been concentrating over the over the course of the year in trying to get that balance between acknowledging the pressures of COVID, but also trying to make improvements where possible. So I'm sure that Martin would want to kind of just, let the board know that F&P has been, trying to get that balance right in terms of this sort of level of scrutiny versus the acknowledgement that it is difficult. And Paul and the team have answered a number of questions to try and kind of facilitate that. So I don't know if that's a reasonable summary.
No, thank you. Anyone else? Can I ask one quick question? Because I've asked this a couple of times and I can't quite get my head around it. So it's about the diagnostic hub and our performance in terms of diagnostics. Because in some of the indicators it looks like that the list is growing. So for example, CT. And yet we hear that the diagnostic hub is overdoing. And so I can't quite... What I don't understand is it that activity is above expected demand, or what's the real picture?
Do you want me
Somebody.
I'll start, and Richard probably won't want to. I think when Richard gave his introduction, he said it was a bit of a double act, really. So I think the first bit is how can we maximise what we currently have is the first question. So the way our provider organisation are looking to improve diagnostics is through a number of ways. Additional capacity, so commissioning external support, trying to find some internal efficient way of doing more with what they've actually got. So when you factor all that in, they are predicting they can achieve just about 120% of previous level of activity. The diagnostic hub is about the future, it's about transformation, it's about redesigning pathways and actually doing things very differently. And they've got, in a sense, their own timeline in terms of when they're going to come up. So there is a here and now issue around how can we maximise the capacity we've got with the workforce we've got, we've got to try and secure the right amount of diagnosis we need to be able to recover. And then I think that a longer term conversation which is around the diagnosis hub and a different way of working moving forward. Richard, is that a fair summary from your point of view?
Yes, but Hassan, I don't have the detail on the specifics around how much of the capacity is online from the Community Diagnostic Centre. There is some, but it's not at full pelt. Part of it they're developing into the phase 2.
Okay.
So happy to speak to Shane and the team around what's the specifics. I think Alison's not in this week, so on honeymoon, but she'll have the figures as well.
I'd appreciate that. It's just, we hear lots of good things about the diagnostic hub, about increased activity, and I guess what I'm failing to understand is and this is a question I put to Shane a while back as well, is that increased capacity, or have we just shifted the activity from one area to the other and we maintain the same level of activity? Because then it's not quite...
I think it's a bit of both,
but
it is about meant to be enhancing the capacity we've got. So let me get the figures for you. I did get the overall number from memory last time, but I think your question's more nuanced around how much of that is actually new and how much of that might be moving from other sites.
And I fully appreciate that we might not be in a position to do that now, if it's a lift and shift. But if it's a lift and shift, are we going to then grow? Is the question? Because then that's
the idea is growth. Definitely. There's no, to be frank, there's no point in spending all this money if it's not additionality. So, but I'll get the specific.
Okay.
But part of it is about the location, isn't it? So there's people in Clacton that wouldn't have necessarily gone to Colchester for the treatment and now got it on the doorstep. So that's part of the answer, isn't it?
Yeah, I mean, I appreciate that. It's about providing access to people. I get that completely. But if, without sounding harsh, if we've robbed activity from one area to the other and the overall activity remains the same, then we haven't won. I guess is the point I'm trying to make. I don't know if is that coming.
No.
Do you get what I mean?
Yeah.
We know what you mean.
Yeah.
I'll find out.
We get you.
All right. Okay. All right. You look confused, Pam. Is that? Have I asked the wrong question?
No, you haven't. Well, there's no wrong question, is there? I guess I was just reflecting on something Ed said in his introductory remarks about volume. I think you said the busiest centre in the east of England, in the country.
Yeah.
So I just made an assumption, but you've challenged that really. That meant increased volumes. It doesn't necessarily mean that.
Well, I think that's what I'm just trying to get to.
Yeah, if I can come, the thing missing in this conversation is a context of increased activity.
Yeah.
So what we've seen is significant increase in activity around cancer, in particular, and on 2 weeks referrals. So the fact that they are managing to stand still almost and to stabilise the waiting is in itself a success. But actually, what we want to do is go further than that, because what we want to do is to recover the backlogs, try to get back down to 6 weeks, which again creates additional capacity. So I think it's quite a complex picture.
I fully appreciate that. Well, I guess the simple question I'm asking is that I get that there's a lot of activity going through the CDH, but I just want reassurance that that's extra activity and not at the expense of activity elsewhere.
Yeah.
So it's just
Just to be clear again, I've got the question. I've just asked Shane.
Perfect.
I understand the question.
Perfect. Okay. Thank you. Just. No, we're just because everyone's looking at me funny, like I'm not making sense. So, or maybe I'm just. No, it's all right. Oh, Prashant.
I think you make perfect sense, Hassan. I think the answer to that is a bit of everything. The capacity has been increased. It's care closer to home, so access is closer to home, especially for people in Clacton, because as a frontline clinician who gets his hands dirty, there's a lot of activity which was sort of delayed or postponed during the pandemic, which is now coming out of the woods. So to answer your question, and I don't have figures, but in my personal experience, I think it's a bit of everything.
I've got one way you could increase the additionality, I like that word, is open it up to GPs to refer directly into, because we've not got pathways that allow us to do. We're still using the same old pathways going into the hospital, and then the hospital uses it. So then you just, so if you allowed us to use our clinical acumen, and which has been denied on several levels, I'm sure my GP colleagues around can agree with that, that we can and can't do this investigation. It'd be quite good to open that up a little bit and to allow us, especially Prashant and myself who work at Clacton and Great Bentley, would be quite good if we could just send our patients straight into Clacton as opposed to, and open up that pathway for us.
I'll ask that question as well. Shane's already come back just to say he'll get that breakdown for us.
Okay, thank you. Right, everyone all right to move on?
Did you just clarify the question?
Yeah. Shall I write it down for you? No. So sorry if I confused everyone.
I do understand. I do. From what I understand, the DNA rates are much lower now for tendering residents to, in terms of attending.
Absolutely not challenging that at all, Max. And I think that's that's great. And that's not the challenge I was putting forward.
No, but I'm just saying.
Yeah. Do you want me to say the question again? Right. Okay. Thank you for the report, Paul. So now we've got a bit of a problem because Martin's not here for REMCOM, but Amanda, you're able to front it for us.
Thank you very much, Chair. So this is our standard remuneration committee report. We last met in April, and we are due to meet, I think, for our final time next Monday, actually. But as the report says, there were 7 main areas of business that we focused on. So we began by having an update on all things CCG transition to the ICB. So we had an update from Susanna with regards to all of that work, particularly focusing on the integrated care partnership that she is leading. We then had our standard workforce KPI report where we discussed things like headcount and the movement over the last period, sickness and the like. We then had our usual report on the management running costs of the CCGs. And then I presented an update on the action that we're taking in response to the National Staff Survey, which I'll share with colleagues shortly. And then we had an update on the gender pay gap information that we're required to publish every year. So they were the main things that we discussed, in addition to our usual report from our trade union meeting. So a good meeting, they were the main things covered, and as I said, we have our final meeting on Monday.
Thank you, Amanda.
Thank you.
Take it there's no questions, and we're asked to note the report. Okay, thank you. Can we move on to the audit committee report? And so Jerry's not here, so Jane, you're going to.
I will take this one. John was also there if I miss anything, but I think the report speaks for itself, very kindly pulled together by Emma. This is reporting on a meeting that was held on 5th of April when we were at the beginning of the final accounts process. So we took the head of internal audit opinion, or the draft head of internal audit opinion from our internal auditors, which was a positive opinion, and it reported on a number of internal audits that had all received positive, what we call positive assurances, as set out in the paper. We meet again as a committee on Friday to with the external auditors to get their initial input on the final accounts, which hopefully will be being approved by the private governing bodies next week. But the rest of it's in the paper, and I've got nothing else particularly to feedback.
Thank you, Jane. Any questions? Okay, so we're asked to note the report, because obviously I forgot he's not here. To thank his leadership for F&P and for Jerry for his leadership of Audit Committee and his role he's had in REMCOM and anything else he's got involved in really over the years in their absence. And sorry they both couldn't be here today. So should we move on to Quality Committee? Lisa, thank you.
Thank you. I'm happy to present the paper, but for the first time I actually wasn't at this committee. I was at the Royal Garden Party,
Shame.
so I couldn't attend the committee. But so
that's a legal party, was it?
So Pam, feel free to chip in, because I know you very ably chaired it. So you will see in 1.2 the committee, as always, received a raft of information. So I think it was 30, a significant number of quality issues. There, from the papers, there were some key points to note. So we always keep an eye on the safer staffing numbers across our providers. It's a report that they have to upload onto their websites, and it's a national reporting to look at staffing fill rates as per their template of required staff. And ESNEFT have seen a drop in staffing numbers for that reporting period, which has taken them down to amber for qualified nights. So 80% of shifts were filled on night. And when you reference it with the unqualified, so this is your healthcare assistant workforce, which was at 41% and scoring red, that's some significant workforce issues that ESNEFT have been experiencing for March. The day was better staffed, so 98% of and 70% of unqualified for day, but the nights were particularly concerning and was obviously raised at that committee. There was, as this was the final quality committee meeting, the risk log was reviewed and risks reallocated either to the ICB quality committee or to the Alliance Committee in North East Essex, to make sure that we don't lose track of any of the risks on our quality risk register. And continuing healthcare in children, you'll know we have an Essex-wide service. There's some concerns around recruitment of the nursing staff, and which means that we're not able to commission CHC through the any qualified provider framework, which leads to risks for the oversight of the quality of care. So that is a concern to note. And there was a paper that went to the committee around the Health Education England visit to ESNEFT, where some concerns were raised by trainees around consultant review of patients and other concerns, which, as I say, the paper went to the Quality Committee, and we're waiting to see the action plan from ESNEFT. Risks identified. So the inquest, the coroner's report into the inquest following the death of Bethany Lilly was taken through to Quality Committee. She was a young lady, she's a North East Essex resident who died by ligature at Thorpe Ward on Basildon Mental Health Unit in 2019, and the inquest found failings which amounted to gross failure to provide basic medical care. The inquest findings is in the public domain, so please, I I think everybody should make sure that they read those inquest findings, and obviously it will be a key part of our oversight of EPUT services around the failings that were found by the coroner. And again, in March, we continued to be concerned about some of the harm we were seeing to patients that was being reported by the East of England Ambulance Trust. Since the 28th of March, that has actually dropped a bit. We're not seeing so many harm incidents being reported, but certainly in March, which this report related to, we were still seeing people being harmed following system delays so ambulances being delayed to patients. And particularly in March, we had 3 gentlemen across Suffolk and North East Essex who died with a delayed response for chest pain. So that was a big concern in March, but it has improved since the 28th of March. And then there's all the other reports which are incorporated in the paper, but they were the key things. Thank you.
Thank you, Lisa. Any questions? Pam, sorry.
Just a couple of points to note as chair of that committee. So Lisa's talked about the transfer of risks. I think we were quite diligent, well, we were very diligent at that last meeting, to make sure there is proper transfer of risks to ensure that the quality oversight remains in the new arrangements. I'm just particularly concerned about some of the items that we regularly discuss in part 2 being brought forward. And my second point was essentially in relation to the views of 2 of the safeguarding leads that were there. And again, it's not a question, it's just an observation that they were very keen to ensure that the local oversight of safeguarding risks, there's an adequate opportunity to escalate those to the ICB board and vice versa. So there was just something about continuity, escalation and oversight locally, really making the most of local knowledge with regard to safeguarding. Thank you.
Thank you, Pam. And did you get that assurance, or have you had that assurance?
I think at that meeting, the assurance came in terms of the conclusions drawn from the discussion, which were to make sure that those concerns were adequately recognised as the new ICB arrangements start to take place, or when the ICB becomes operational on the 1st of July. So I'm raising them here as a sort of extra bit of assurance that that doesn't get lost.
Get lost, okay.
Because there's always, it's such a big transfer of responsibilities, isn't it?
It's I think that we'll get that across all of our spheres, really, to be fair. Lisa, did you want to?
Just so, as you'll be aware, Linda Moncure, who is the substantive Deputy Director of Nursing, is currently in MSE. So I'm directly overseeing the safeguarding teams at the moment. I'm giving the safeguarding teams their supervision. So, and they raised it with me as well. So we've worked through exactly how safeguarding will be raised, escalated, but also thread through everything as part of the Alliance and part of the ICB. So I think they are they're happier now, but it's a time of transition, and I think staff are just trying to work through, as you know, we feel more confident now where everything's going, but they're still trying to work through how their bits of portfolios will be feeding, and I think that was just an example of one of them.
Okay. And you don't plan to spread yourself that thin for much longer, do you, Lisa? We've got a replacement for...
Yes, we have, yeah.
Okay. So thank you. Any other questions? Everyone's looking a bit glassy-eyed now, because face-to-face meetings, no one's used to being able to pay attention for such a long period of time. Right, so let's move on. Well, I was looking at... you look off. No, I wasn't... No one in particular. Although I appreciate I was looking at you when I was saying it, but it's just... I've got to look somewhere, Prashant, don't I? So, Primary Care Commissioning Committee. Pam.
Thank you very much.
Thank
Thank you, Chairman. So I'll take this paper as read, but as our final report as a membership organisation, I'd like to take the opportunity to thank John for your incredible leadership in the Primary Care Commissioning Committee, a committee of this board but held in public. And I think under your and that of Oge Chess as the Deputy Director of Primary Care, we have moved to a very open and transparent reporting of primary care in the time of that committee's life, and we've also had the ability to challenge and put in remedy actions around primary care quality, commissioning, and the wider areas of performance that we needed to in the time. One notably being around the SMI health checks, and Richard's team and my team have worked together in a model that has truly made a very quick difference, quicker than we thought it would, in fact, and delivered really innovative checks for that group that suffer from shorter life expectancy because they don't engage with primary care, even though it's a trusted source for many others. I'd like to thank Joe Sunderland from GPPC, who has supported us to develop an integrated service, and for that reason we were able to report not the full recovery but a significantly recovered position of SMI health checks in quarter 3 and quarter 4 of last year, which is excellent. That some of the other work that we've overseen, I think one of the things we're trying to do through this group and more broadly through the Alliance is get the PCN network desk truly understood by all members of the Alliance, because it's one of the real levers within the system to engage primary care in a more broad sense across the committee, across the ICB going forward. So lots going on, and I'm very proud to show the sort of figures and the reporting that we've got. Initially rejected by the LMC as why would we need that level of transparency, to endorse by the LMC, which I think is very, very positive. The LMC is supporting us to do a piece of work, again in partnership with the workforce team, around discrimination and racism faced in primary care, a model that was rolled out across Humberside LMC, and I think that's very important, keying into the retention and recruitment matters that we've discussed earlier in the meeting. So I'm happy to take any questions, just noting that QOF is not fully reported as yet because of COVID suspensions.
Thank you, Pam. Can I also echo a thanks to you, John, for your leadership, and I also missed the opportunity to thank you, Pam, for quality. Sorry. So questions?
Yeah, I've just had a great deal to add, because that was a very thorough report there from Pam. Other than to say, really, we've got our next meeting on the 14th of June, which will be our last meeting, and amongst other things, we'll look at what we might need to do in terms of a handover to the Alliance as we move forward. And perhaps at the risk of it sounding like a mutual appreciation society, I'd like very much to thank Pam, Ogie and their team for all they've done to support me, and also the other members, Myrna, who's also a member of the committee, Health Watch, the LMC. Everyone's made a great contribution to the work of that committee in the last 5 years. I don't think we would have achieved what we would have done without everyone working together to that end. So thank you all. And
also John Flathers, who's our out of area GP, indeed, who's been incredibly helpful, and is and a constant throughout. And so the governance following. It's not necessary for us to have a primary care commissioning committee per Alliance going forward. So we're going to have a primary care operations group, and we've asked John if he will continue to support that. And also that means we can have some objective view into the area around primary care performance. So.
Max.
I can just notice on the report that we've got a sort of slight dip in the diabetes, which obviously I would like to see that being kept a lid on, because I mean it is such a good area of success in North East Essex, and I just wonder, actually going forward, there'll be presumably a GP commissioning, primary care commissioning committee for the whole of SNE, is there going to be some sort of learning about what that's achieved, you know, as compared to Suffolk? I mean, you know, because I think that sort of collaborative working between primary care, a GP provider service, and Suffolk Fed and acute services has really achieved some fantastic outcomes, which we kind of want to see replicated through the whole of SNE. And actually, personally, declaring my interest, I would actually like to see in other areas as well, you know, and actually sort of try and commission that in other areas where we do, you know, do try and improve outcomes, you know, reduce inequalities again, by getting everybody working together, you know, community, primary care, acute, you know, diabetes is a great example, could happen in other things like heart failure, other areas could do the same thing and achieve the same sort of outcomes that we've seen here. Sorry, that was a bit long.
It was, but I can remember the thrust of it, so don't worry, I'll respond, Chairman, if you would like me to.
It's a bit late now, you've already started responding.
Okay, thank you. There is a slight dip in performance, but we understand what's driving it, and some of that was to do with access during the COVID period, so and workforce availability. So we're working with Suffolk Fed to look at that. Now, what we have done is incorporated the diabetes service into the NICS contract, so the community services contract, subcontract by the acute hospital, which is very novel actually for Suffolk Fed, because that's not a relationship that they've had on diabetes in that format before. And it's currently, as we've talked about research already in this this meeting today, there is a piece of exploratory research being done on that service to determine why it has produced such fantastic outputs. Now, I think I could probably write that because we've lived and breathed over 7 years the what's made a difference, and what's made a difference is embedding workforce into primary care and supporting primary care to actually be the front of house. That integrated model actually is very, very important to the delivery of specific services. So we've got it enshrined in a model within the NICS contract. There's the availability to put more services into that sort of format. And don't forget, GPPC, our local federation, have also just had their CQC rating redefined, not rating, what's the word I'm looking for? You can't think of it now. The accreditation, whatever, has been redefined such that they can now offer clinical services and host clinical services. And employ clinical staff, which they couldn't before. They were an interface service. So there is all the opportunity to do that for more services. Yes, Max.
Happy? Okay.
Sorry, very quickly. As Pam is leaving and we have a new Alliance Director who is going to be taking over your role in primary care as well, presumably there will be some overlap period. I don't know how much, but there's so much for her to learn. I mean, there's so much. It takes yonks to get a grip of some of this. So I'm sure, is there an overlap? Is there, in terms of her induction?
Can you answer that, Amanda or Ed?
I'm sure we can do a joint effort. I'm sure there is an overlap and a period of, I think, Pam, you've already started some kind of handing over or about to with Laura?
Yeah, I'm going to do some sessions with Laura to hand over particularly the specifics around primary care management. And Oge, of course, as my deputy, will be staying to impart that information. Yes, she's here.
Okay, right, thank you. Sorry, I tried to rush everyone, but we're a bit behind. I'm out of practice. So, Alliance Committee, yes.
So again, I'll take this paper as read, and following some of the videos that you've seen this afternoon, which have embodied and hopefully brought to life the Alliance work, this report gives you the updates from the governance structure embedded in the North East Essex Health and Wellbeing Alliance, our domains, and the supports services that and enablers that we've had established and wrapped around us in the Alliance, which which are now starting to really support us to deliver different things. Notably, I would like to draw your attention to the fact that we have renamed our equalities group to the Widening Equity for Local Lives group. So when you see WELL, hopefully that will now resonate as our health equity group. I think it has a lot of meaning to it, and Kate Croft, who's our equity lead, is mantling that strength around health inequalities in everything we do, and it's becoming a very powerful movement. So I'm very supportive of her work. The neighbourhoods team, as we have again seen through the videos today, is delivering in Colchester Central now, running its multidisciplinary teams to solve complex cases and supporting primary care. They're rolling out into South Tendring and South Colchester in the next couple of weeks, so that's very positive for the full rollout across North East Essex, and hopefully by the end of the year we will have all of our neighbourhood teams in place. And again, we've got full support from all our partners in making that happen, and special thanks to Pam Donnelly for your support in the Colchester Central, because you were the first organisation to release your staff into that way of working, which truly enables us to focus on the wider determinants of health as opposed to the consequences of ill health, which we have traditionally commissioned and contracted for. So true prevention model, and it's starting to come together. We're doing a piece of OD work with our team, which again we would like to showcase in the new ICB, probably at the People Board, if Amanda would be supportive of that, around how we're bringing together the teams and getting them to work differently. So lots going on in Clacton Place as well around levelling up. The joint prosperity, shared prosperity funds bids are currently being worked on across the Alliance, and lots of support. And I think, Frida, that is one of the areas that we're looking to support primary care estate through, because it is a novel way of getting some capital. It's then looking at what we do about revenue consequences of that, which are incredibly complicated. But we're ambitious to bring to the local Alliance geography some levelling up funds into health for that, and our local authorities are supportive of that. So I will take any questions.
Thank you, Pam. Any questions? No? Okay, well, we're asked to note the report. Thank you.
Thank you.
WELL, is it? W-E-L?
Well.
Well, okay. Are they going to get some fancy fleeces as well, like everyone else? I haven't got one yet.
No, you're not getting a fancy fleece.
Charge up to the ICB.
Along with the sandwiches.
Charge it all to the ICB.
Should I go on to procurement
yes,
update?
Yes, please. So we'll note that report. Thank you.
Thank you. And great thanks again to the all of the system partners in supporting that work. Procurement update. So this is our usual pipeline of procurement that's going on, procurements that have been delivered, and the future way of working, and an update on our transition to the ICB board and how procurement will be delivered. We work in North East Essex with Attain as our procurement partner, and they are working alongside our in-house staff as well to create one team to deliver the procurement advice, guidance and administration for the ICB in the future world. And the procurement guidance is looking to change for clinical services and non-clinical services, but there's a disconnect in the time frame of those things. So we will be working on several different sets of guidance for procurement for a little while. But Paul, you may want to comment on the fact that we've got the procurement committee starting that will be well versed on all of the aspects of the procurement legislation as it starts to catch up with itself and the changes that are required to make that happen. So happy to take any questions. And
do you want to say anything?
If I may, thanks. So just to give assurances to the governing body that the teams are working together to align all the policies, otherwise working to get the best out of both sides, if that makes sense, in terms of getting arrangements in place for the ICB. The other issue, which isn't in the paper, is that they are working on training material in view of the changes, because it is going to be very different the way we are expected to procure in the future. There is a bit of an overarching view that procurement will be easier. Actually, it's likely to be more challenging in terms of the process that we currently have. So again, people will need to understand what the process need to be. The procurement committee will be a place to keep the system safe in terms of consistency of approach. It will not be to take away the power base of various committees to do the awards. That will need to remain. So they are currently mapping that how that's going to work in practice. So again, that work is ongoing, ready for transition to the ICB.
Perfect. Okay. We're good at making processes more complicated, aren't we?
Well, it's not. If I can just say, whilst there's more freedom, the diligence and the audit trail associated with gaining that freedom has to be just as rigorous, if not more rigorous. So the process is not more complicated. The evidencing of the decisions you make will be.
Tomato, tomato. Right. Thank you. Questions? No. Okay. Thank you. We will note that report. Are we still with you, Pam? Are we?
Yes, Area Prescribing Committee. So as I always comment on this report, whilst we're a non-clinical majority within this this board here, this is a subcommittee of the board and is given delegation to make decisions around prescribing and formulary. So the group works across SNI and is effective in influencing all of our partners around their prescribing and prescribing safety. Prashant attends, so I will ask for comment in a moment. But it will in future be going to our professional clinical committee so that it can have endorsement from the clinicians and by clinicians, and there will be a single report that goes up to the ICB. So it will enable a broader clinical majority to scrutinise the decisions made.
That'll be neater. Prashant, did you want to?
Yeah, just comment that I think it's a good committee where all the three areas are represented. You have the three hospitals represented, you have EPUT represented, and you have the backup team of OGI and the medicines management group with the interface pharmacist who then collates information throughout the three CCGs. So towards that end, I think we talk about new drugs, patient drug safety, how to sort of then apply for the new drug to then become a part of the normal formulary in our local area. And also sort of look at making common forms for shared care and stuff like that. So very interesting work because it's quite clinical. But you see a lot of new drugs coming in, and you see a lot of existing drugs used in other areas. So yeah, it's quite interesting work.
Okay. Well, thank you, Prashant, for attending and being our representative and clinical representative at that meeting. Any questions around the content? No? Okay, we're asked to note the report and we can move straight on to crack.
Yeah, thank you. So, possibly the last time that I'll ever report on crack, which when we named it the COVID Resource Approval Committee 2 years ago, I realised it would still be going at this point. But anyway, so since we last reported to the board, there has only been one meeting. The decisions that were detailed in Appendix 1. They are really mainly around COVID vaccination and around the retrospective approvals for the elements that we were funded last year through the hospital discharge programme around that interface between health and social care. The reports on the crack committee do go in detail to the Finance and Performance Committee, so I will leave it there and just see if anyone's got any questions, if that's okay, Chair.
Has anybody got questions? No? Okay. Did you want to say anything else, or should we move on? There won't need to be a crack anymore, will there, with ICB? It sort of defeats the purpose.
Yeah, no, absolutely. I mean, the reason for convening it was around speedy decision making across the three CCGs, so hopefully a reduction in COVID and bringing the CCGs together will reduce the need.
And thank you, Jane, for all the work you put into, or contributors, I should say, to crack that you front, because actually it was needed, and those decisions sounds wrong. Thank you for contributing the crack, but it made for a great meeting. but no, you know, actually it was needed, and actually in the. I'll move on. Thank you. We'll note the report. Yeah, I'll just move on. Right. Thank you.
I'm looking forward to tomorrow's headlines.
Live stream meeting. Yeah. Share thanks for Anyway, move on. Staff survey, Amanda.
Thank you very much, Chair. So here we have our staff survey results, which were finally published in February of this year. So this is as a result of the survey that we undertook last autumn during October and November, and we surveyed all of our workforce against 9 domains which are shared in or included in section 1.1 or even 1.2. And we had a 66% response rate, which wasn't bad, wasn't good, it was average, but we will accept that. So in section 2 we can see the key areas of our results, and it's very pleasing to see in all of the 9 areas that we were surveyed, we actually scored above average in every single one, so that's really good news indeed. And we can see in section 2.2 those areas where we scored above average being the best, and they are working flexibly, working as a team, and working as a compassionate and inclusive employer. And then we can see our top 5 scores, where we can see again very pleasing results compared to the CCG average across the NHS. And we can see that we actually perform very well in terms of dealing with harassment and bullying issues, disability, allowing our staff to achieve a good work and home-life balance, and committed to supporting that balance at work, and really supporting in terms of burnout. We can then see that we have got areas where we need to be improving, and these are no surprises. We know that we need to be better in giving basically our staff the kit and the IT kit to do their jobs within the office or indeed at home, and that's something that we are working through with our digital team. We also need to up our game in terms of making sure that all of our staff have an appraisal and PDP, and we are working with our respective teams to improve that as we move forward. And then obviously linked to that is ensuring that all of our teams have shared objectives. So no surprises there, but we will continue to improve as we move forward. And then moving on to page 4, we can see as a CCG ×3 how we compare to other systems, and all bar 1 we actually scored the best, which I think is really, really good news indeed. So the bar graphs speak for themselves, and I think we should be very pleased with those sets of results. So in terms of our action and planned next steps, we have started this work several weeks ago, and we continually update our remuneration committee and trade unions on our collective work. But as we can see in section 3.2, that we are working through appraisal and PDP, we're working on MSK issues and ensuring that we can improve the health of our staff by giving them appropriate techniques and support, and also ensuring that we can improve our digital and IT equipment. So work in progress, and that's something that our remuneration committee will continually monitor, and that will actually transfer into the ICB from the 1st of July. So work in progress, but I think compared to where we were this time last year, we have seen a notable improvement in our staff survey. We're not complacent, we know that we have got to improve, but I think it's a very good set of results. I'll leave it there, Chair, but very happy to take any questions.
Thank you, Amanda. It's good to hear that we're not going to be complacent. I think, as you say, even with the top 5, I think there are some figures there that actually one wouldn't be too happy about if it weren't for the fact that it's got a green sticker around it. For example, it's not great to have a 47%. That means more than half of our staff are feeling burnt out, which, to be fair, probably is a reflection of everyone in the system. Is probably the reality of it, isn't it? But I think the important thing is that we've got a plan for trying to address these things and not settling for those as good. But has anyone got questions or comments to pose around that? No. Pam?
So when you say it will go forward into the ICB, is it that the same staff survey will be undertaken as per the rest of the health providers across the ICB, or will there be a different tool?
Yeah, so a couple of comments, Pam. So in terms of where we are as a current CCG that will transition into ICB, there's clearly action that we're undertaking that will continue to be moved forward when we get into that arena, and those actions will be monitored and more through our new remuneration committee. There will be a staff survey this autumn. We don't know yet what that will look like, but I'm sure it will be a bit different to what we're experiencing, because clearly CCGs will no longer be there. It will be at an ICB. So we await further information.
And do we think that that will feature in our own CQC?
Without question, I'm sure it will do.
Assessment.
Particularly as part of the well-led element.
Okay. Thank you. Anyone else? Okay, we're asked to note the report. Let's move on to declaration of interest. Should we just take this as read? Amanda, did you want to?
Yeah, I think we take it as read. It is our biannual report that comes to governing body. There's probably nothing that I want to add. It is what it is. It shows our current register of interest, and I think it's for the governing body to note.
Okay,
thank you.
And once again, if there's anybody that's got an interest that's not listed on there, then please let Joe know for the next 23 days. So we'll note that report. Governing body, the assurance framework. Who's talking? Amanda.
Yeah, thank you very much, Chair. So here we have our latest risk register, which contains 11 key risks that we continually seek to manage and mitigate. And as we can see, we have got an update on each of the risks as shown under section 1.1. So, for example, with regards to the Clacton hospital site redevelopment, we're near on completing an updated OBC, which will go through the required governance as we move forward. In terms of workforce, I just wanted to inform the governing body that through the review of the System People Board, we are now refreshing each of the 3 aligned workforce groups, and there is work in progress with regards to that. Cyber is what it is. Continually work and monitor with our IT providers and mitigate as far as possible, and we regularly report on our actions undertaken through the audit committee. I will invite other directors to update on any risks that we haven't covered thus far, but I just wanted to note, Chair, that going forward, clearly we will be updating our risk register. It will go into the new ICB from the 1st of July, and it will also go into each of the 3 alliances. So we will be migrating from where we currently are into a ICB and alliance infrastructure.
Thank you, Amanda.
Thank you.
Any questions? Okay, well, we asked to note that. Health and wellbeing update.
Very much, Chair. So this is our usual update on all things health and wellbeing, and as we can see in the report, we continually, I think with pace and rigour, continue to support all of our staff on all things health and wellbeing. And as we can see, we now have 24 health and wellbeing ambassadors across all 3 sites, and they continually promote and encourage all things health and wellbeing activity, and feedback is suggesting that is being well received. In addition to that, we have 13 now trained in mental health first aiders, so again additional layer of support in terms of the health and wellbeing agenda. The internal CCG health and wellbeing team are now linking into the system health and wellbeing team, where we're looking to collaborate and join